Hello, welcome to the Pediatric Brain Tumor Foundation's webinar today, The Childhood Cancer Community's Biggest Crisis, What You Need to Know About Pediatric Brain Tumors' National and Local Impact and Ways that You Can Take Action. My name is Heather Held, and I am the Director of Family Support for the Pediatric Brain Tumor Foundation. We are honored to have you joining us today for this important webinar. Before we get started, I do have a few guidelines to review. You are muted for this webinar and your video is disabled, but we welcome questions during and after the opening remarks. Please type your questions into the Q&A feature found at the bottom of your Zoom window. We will not get to every question, but we will try to get as many answered as possible. We have three presenters for you today, starting with Dr. Quinn Ostrom. Dr. Ostrom received a PhD in epidemiology and biostatistics in 2018 from Case Western Reserve University in Cleveland, Ohio, completed postdoctoral training in integrative cancer epidemiology at Baylor College of Medicine in Houston, Texas, and is currently an assistant professor in the Division of Neuroepidemiology within the Department of Neurosurgery at the Duke University School of Medicine in Durham, North Carolina. Her primary research focuses on using population-level cancer registry data for surveillance and risk factor discovery for primary and metastatic brain tumors and discovering sources of germline genetic risk for primary brain tumors. Dr. Ostrom is a scientific co-PI of the Central Brain Tumor Registry of the United States and leads production of the CBTRUS annual statistic report. It gives me great pleasure to welcome today Dr. Ostrom.
Thank you so much. Thank you so much for the invitation to participate on this webinar and be able to kind of give you a brief summary of some of the recent statistical analyses that we were able to do as part of our special report funded by the Pediatric Brain Tumor Foundation, focused on brain tumors in children and adolescents 0 to 18 or 19. So even though brain tumors are a relatively rare cancer in the kind of grand scheme of cancers that are diagnosed in the US, they are the most common type that is diagnosed in children and adolescents. So on average, there are about a little more than 5,000 new cases of these tumors diagnosed a year, and that includes all subtypes, of which there are many, and a little over 500 average annual deaths due to this disease. And if you look at this in kind of the overall incidence or the amount of new diagnoses that occur in the overall population of children and adolescents in the US, it is higher than other common childhood cancers. So there's about 1,000 more brain tumors diagnosed a year on average than new leukemia diagnoses, as well as more than lymphomas, other epithelial neoplasms, and sarcomas. Next slide, please. And if you look at incidence of brain and CNS tumors in children and adolescents over time, so this is just showing you the frequency of new diagnoses in the population 0 to 19 in the US by year from 2004 to 2018. Brain and CNS tumors are in red, and then you can also see leukemias, lymphomas, soft tissue, sarcomas, bone tumors, and then germ cell tumors that occur outside of the CNS. And so you can see that consistently across this time period that, unfortunately, incidence of childhood cancers in general has not gone down in the way that we would like it to, but that brain tumors had been consistently, new diagnoses are more frequent than any of these other comparison cancer groups, and that to some extent there appears to be a slight increase in incidence of these brain and CNS tumors, at least over this time period. Next slide, please. So over a longer time span, though, so this is data related to deaths due to cancer in children 0 to 19. And this includes data that goes back to the late 60s, so 1968 through 2018. And so you can see that, one of the great success stories of childhood cancer research has been this large decline in mortality due to leukemia. So you can see that purple line, that there's really a substantial decline, but that one thing we haven't seen are similar gains in survival on a similar scope for brain and CNS tumors. So if you look, there has been, maybe a slight decrease, but it's unfortunately been relatively stable. And to the point now where mortality due to leukemia has now dropped below that of brain and CNS tumors. So you can see that right around 2015, that those lines cross, and mortality due to brain and CNS tumors in children 0 to 19 is now higher than mortality due to leukemia. Next slide, please. And so one of the major factors that affects both research in brain and CNS tumors in children and adolescents, and then surveillance, is that it is a really complicated group of diseases. So this kind of shows you overall for new cases that were diagnosed between 2014 and 2018 in the US, that they occur in a lot of different locations in the CNS. If you can see on the left, so those are just different locations in the brain and central nervous system, and that there are a lot of different subtypes that are frequent, or that you have to contend with. If you look on the right, this is we actually have more than 100 different individual codes that classify new diagnoses in the data that we use, and we group them into these broader categories for analysis. And even when we do that regrouping, we still end up with about 20 or more different groups. The vast or the majority, the larger plurality of these are kind of broadly what we would consider to be gliomas, but that even within glioma, that's a very heterogeneous group. You have lower grade gliomas, pilocytic astrocytomas, high grade gliomas, and in particular within high grade glioma, would like to point out that while we don't have a specific code, unfortunately, for DFPG or diffuse, the midline gliomas, that approximately 30% or 60% of that, those high-grade glioma cases actually occur in the brainstem. So that's a very large proportion of the high-grade glioma burden in this population. The other large contributors to this are pituitary tumors, which are particularly more common in adolescents as opposed to younger children. And then the other major group would be embryonal tumors, of which medulloblastoma is the most common. Next slide, please. So one of the other statistics that we calculated for the purposes of this is something called prevalence. And so I had previously mentioned incidence, which is looking at new diagnoses per year, but prevalence takes into account the total number of people in a population that we estimate to be surviving, living with a particular disease, regardless of when they actually were diagnosed. So these are estimates for, as of this year, 2022, the number of children and adolescents ages 0 to 18 that we estimate to be living with particular cancer diagnoses. And so you can see here that brain and CNS tumors are only slightly behind leukemia in terms of being by far the greatest, the largest population of childhood cancer survivors. And just to be clear, this doesn't include children that have children or adolescents that or individuals that were diagnosed as children or adolescents that are now older. So this is just children who are 0 to 19. But that they really have brain and CNS tumors contribute substantially to the survivorship burden in this population. Next slide, please. And when you break down that approximately 40,000 children that I showed on the prior slide by the actual subtype of brain tumor that they are surviving with, living with, you can see that there's a lot of diversity. It's heterogeneous. The biggest contributor to that number is by far is pilocytic astrocytoma, followed by lower grade gliomas, medulloblastomas, and then tumors of the pituitary. And you can see, the other kind of contributors. These are the top 10 of those groups that I previously mentioned, that we estimate our children are currently living with. So it's quite a substantial population of children, considering that these are a rare disease. Next slide, please. So I just wanted to briefly acknowledge our research team, without whom we wouldn't be able to do this work. So Carol Kruchko, who's president of CBTRUS, and then Jill Barnholt-Sloan, who is my co-PI, and then the research staff at NCI, where Jill is currently located, and then my research staff at Duke. And just, also wanted to point out that this data depends on a big network of tumor registrars, central cancer registries, and a lot of different folks that are able to put together these really large data sets, where we're able to use national data covering, the entire US, to really get a handle on the burden of brain and CNS tumors in children and adolescents. And thank you again for asking us, and I'm looking forward to the discussion and the rest of the webinar.
Thank you so much, Dr. Ostrom, for laying the foundation for us really today as we dive into this statistical report and the impact within our childhood cancer community. As we continue today, I'd like to introduce our next presenter, Dr. Scott Coven, who will speak to how this report might impact work within the clinic setting and why it's important to the community that he works directly with. Scott is an assistant professor of pediatrics at Indiana University School of Medicine and a pediatric neuro-oncologist at Riley Hospital for Children. His clinical interests are in neuro-oncology with a special interest in cancer survivorship and public and global health. His research interests include promoting awareness of childhood brain tumors and investigating how disparities in care, specifically delays in diagnosis and social determinants of health, impact clinical outcomes. When not working on various job-related projects, Dr. Coven enjoys watching or playing sports, spending time with his family, and traveling. It gives me great pleasure to now introduce to all of you Dr. Scott Coven.
Well, thank you very much. I appreciate being a part of this webinar and seeing the wonderful kind of co-attendees and individuals. And the Pediatric Brain Tumor Foundation is obviously a organization that means a lot to me in my young career over the past 10 years or so. And while this says updates, it's probably more implications from a clinical aspect. And so I hope you'll get some through to some of that. And I think Dr. Ostrom did a great job, and probably we have a lot of slides in common, so that'll be great as well. Next slide. And obviously I have nothing to disclose from the clinical aspect of things. So, I do want to go over obviously some of the epidemiology features because, as a clinician and doing, research specifically with kind of delays in diagnosis of childhood brain tumors, I've given grand rounds with slides just like this for the past 10 years, and actually gave grand rounds yesterday. And really until yesterday was I finally able to say what I felt, which is how common, or the fact that childhood brain tumors are the most common childhood cancer. And I think that's a really key thing as we move forward, for the rest of this webinar and in the future, is recognizing that, because of the CBTRUS, we're doing a better job of really finding all of the patients that are out there really documenting their journey as best as possible. Previous presentations, I would have said that, we're only seeing around, 5,000 new cases, but we are seeing, 52, 60 new cases or so. And the incidence is up to 6.23. In the past has been around 6.11, I think, through CBTRUS's 2021 release. I think we all know that besides homicides, suicides, and accidents, brain cancer accounts for the highest disease-related mortality in children 0 to 19 years of age. This is always a key statistic I give to my general pediatrician partners, because I think, many of them think, diabetes or lupus, seizures, some of these other diseases, which are probably more common, would cause more disease-related mortality, and that's actually not true. Next slide. I do want to point out again that the most common pathology group is pilocytic astrocytoma, and Dr. Ostrom did a real good job about talking about, that bucket of gliomas, the low grades that are often our most common childhood brain tumor, but are again a very kind of heterogeneous group of tumors. And honestly, all of them act very different. And I'm sure as parents and caregivers and family members, all have a different journey. I think another key statistic that I saw was the median age of diagnosis was 9 years of age, something I wanted to point out. And I think what is really interesting, and again, giving grand rounds over the past 10 years, I've always quoted the SEER data, which is kind of another epidemiology related database that quoted the overall survival for children with brain tumors around 85%. But what I thought was really interesting is the note in this group, or this release, the 5-year survival was 84%. And this is really interesting because we're getting into even higher numbers where, traditionally leukemia is thought of kind of the most curable childhood cancer, and now pushing into the over 80%. It's not necessarily how we continue to do better, with survival. It's now how do we do better in kind of reducing treatment-related effects? How do we do better for those who are survivors of childhood brain tumors? And how do we kind of use these data to really push the kind of survivorship field forward? And then obviously you can see those last two data points that the highest survival was in adolescents, and the lowest were often in our youngest children who typically have the most aggressive childhood brain tumors. Next slide. Dr. Ostrom did a good review of this slide as well, just again showing kind of those overall incidence or overall prevalence of patients living with brain tumors, and it's really approximating childhood leukemia, and showing on the B graph kind of those cases that are related to pilocytic astrocytoma, which is obviously the most common pathology group we have. Next slide. So I wanted to switch away from the CBTRUS data for a few slides to show you now the World Health Organization slides. And these are kind of our key, two big key publications that we have between the CBTRUS and the WHO. And this release of information is directly related to the pathology that we see. And what I want you to really take home is how busy this slide is, because this tells you everything about pediatric neuro-oncology. All the brain and spinal cord tumors we see are not 1, 2, 3 diseases like childhood leukemia or our solid tumors or retinoblastoma. I think what makes neuro-oncology such an art and such a challenging field is this right here, is the fact that there are over 100 different types of childhood brain tumors. No child presents the same way, and no tumor really acts the same way. And so I think for, as we move forward over the next 5 to 10 years with the CBTRUS, it's how do the registries continue to push these kind of global diagnoses of of what's been going on in the past 10 years, and now pushing that forward into these databases so that we can better track clinical outcomes for the future. Next slide. Again, Dr. Ostrom showed this slide, and again, I think this also shows in a different way how complex childhood brain and spinal cord tumors are. If you put childhood leukemia on the slide, you would see three. You would see chronic myelogenous leukemia, acute lymphoblastic leukemia, and acute myeloid leukemia. You'd see three in that whole pie chart. And right now you can see over 20, and that doesn't even speak to all those other pathology features we found. And so again, I think from a clinician aspect, this is where my heart is in seeing how complex when we have new patients, when we see our older patients, to talk to some of these aspects of things. Next slide. Again, now switching back again to the WHO data, I think this is the future, this in the next slide. And this speaks to maybe what many of you are starting to hear about, which is kind of the evolution of molecular testing, or kind of whole genome sequencing, or methylation profiling. What I would say is more precision tumor typing. And that is kind of an augment or an addition to those hundred different types of tumors. And I think the field is moving towards the sequencing or the advanced testing of, at least at our institution, every tumor that comes to us, obtaining broad precision type testing. And so I think it'll be key over these next years to utilize what we've learned over the past 10 years and start really enhancing the state registries, the CBTRUS data, to really, evolve into how do the precision testing affect clinical outcomes. And if you look at the next slide, I think that picture really shows this. So what you have, the top and the bottom are two different subtypes of diagnoses. But what you have are, what we call an integrated diagnoses. And it's something that's included with a histopathologic classification. What is the pathologist seeing under the microscope? With what do we see with those extra special tests that we can do right now to really drive the field further? I think the second example does that a little bit better. If you look on the bottom, you see an integrated diagnosis of that shows the kind of overall. But if you see the histopathology, it says it's an oligodendroglioma. But then if you look at the molecular information, you have a key driver biologically that's affecting this tumor and its growth. And that leads to an integrated diagnosis that pulls in and meshes both of those. I would say that many of you may have heard of this, over the past 5 years, but this has really been evolving quickly. And I think, again, over the next 5 to 10 years, probably where Dr. Ostrom and Dr. Kreshko go with their work is, how does this really factor in, and how can we better follow kids over time with these integrated diagnoses? Next slide. And I think this may be my last slide, but as Heather said, one of my kind of passions is survivorship, and its key impact is really neurolong survivorship. And when you look at the long-term data, childhood survivors or adult survivors of childhood brain tumors tend to be those who have the most chronic and comorbid conditions. And, I think that speaks to everything our kids and adolescents go through at a young age, with the fact that they need, surgery, oftentimes chemotherapy, radiation, different medical treatments over that time. And, I think these were two paragraphs that were honestly some of the last kind of points of this whole release of information, but I thought were really key. And I think for me as a clinician, as I move forward, and hearing overall survival 84%, Dr. Ostrom's work showing now the overall prevalence of childhood cancer, brain tumor survivors living as much as leukemia survivors, is finding ways that us as the members of field, and that doesn't just include me, right? It includes researchers, parents, caregivers, PBTF, to really evolve our work in survivorship, to reduce late effects, to raise awareness on late effects. And I'm often quoted as saying survivorship starts the day of diagnosis. It's how do we start focusing on being a survivor now, especially with improvements in access to treatments, different types of modalities of treatments. The improvement to 84% is huge, but I think it's even more important now that we're focusing on our long-term survivors, that we're reducing late effects, reducing treatment-related morbidity. We're advancing awareness and advocacy on the front side so children can be diagnosed sooner, and so that we can have better and more long-term conversations as children mature over time. Next slide. I think that's it. Great. Well, thank you for having me today. Look forward to all the great questions.
Thank you so much, Dr. Coven. I think I'm going to walk away with this one statement in my head forever, that survivorship starts at the day of diagnosis, and how can we do better together for these kids. So thank you for sharing that and really giving us your unique perspective. I'd like to now introduce our final presenter today, Mike Henry. He is our Director of Advocacy for the Pediatric Brain Tumor Foundation. Mike is the father of Eternal Star Blair, who passed away in 2020 from a rare embryonal tumor. His past work includes working with political, religious, and higher education nonprofits on policy and fundraising initiatives. And now Mike puts his expertise and his passion into the work that he does here at the Pediatric Brain Tumor Foundation. So I will go ahead and turn it over to you now, Mike.
Thank you so much, Heather. So really, what does this report mean for advocates? I think this report really validates what we already knew. This is the biggest crisis facing the childhood cancer community, and that's not news to anyone that's been touched by this disease, but we finally have data that bolsters what we all feel. One of the things that struck me is the total amount of tumor types. It's really mind-blowing to see the over 100 different types of tumors in that pie chart from the report. And for many of us, this fight is so personal. We can't help but view the problem through our lens, and I'm certainly guilty of trying to contextualize everything through my own personal experience, my daughter's experience. But the report is really helping me understand that there is no typical experience for those children diagnosed with a brain tumor. These are complex problems that will require complex solutions. It could be really easy for me to focus on the specific tumor type that killed my daughter, but this report has given me insight into the broader scope of the problem. This is way bigger than any one subsection of the community. I think the most effective thing that we can do as advocates is to start viewing ourselves as a member of that larger pie chart, as opposed to the individual slices within that pie chart. The biggest issue facing our community is a small patient pool. And these small patient pools are not often prioritized by the healthcare community. So further fracturing any of the already small patient pool could totally undermine our overall progress. I think that progress will come if we coordinate and work towards goals that will benefit the entire community. I think this report also helps us understand the broad scope of the problem throughout the entire US. The problem isn't isolated to any one specific area of the country. When we look at the list of states that rank high in either incidence or mortality, we see that this is a problem really for every US citizen. Not every state is equal. I'm not just talking statistically. I think there are challenges within each state, like access to care, that can exacerbate the problem and lead to either higher incidence or mortality rates. Each state is totally unique. We have useful data from this report, but there is a lot that we still don't know about the cause of these diagnoses. So we need states to really start answering those questions. Can we move on to the next slide? So that leads us to the question of what can we do? Well, first, you can join me in our advocacy efforts. You can sign up to be an advocate using our website at curethekids.org/advocacy. We really need leaders that can help drive our efforts. Advocacy can take on many forms, and we are here to help you find the best way to take action. Just using 2 examples on the local level, we are partnering with our friends from the Coalition Against Childhood Cancer to work with state level advocates on improving cancer plans. States are given funding from the CDC to draft and submit cancer plans that address the burden of cancer care within their region. Unfortunately, many of those plans totally omit pediatric cancer language altogether. We're on a mission to change that. We're bringing together stakeholders from within states to advise the groups put in charge of drafting those plans. These groups will include members of our community, as well as those representing other types of pediatric cancers. Clinicians also have a very important role to play. We need voices from within the hospitals in each state that can help us address the specific issues facing the medical community serving our patients. On the federal level, we can engage legislators on policies that directly affect our kids. We have 2 great examples currently sitting on the desks of Congress. One piece of legislation addresses key research funding, and the other addresses access to care. So first, the STAR Reauthorization Act is a straight reauthorization of an incredibly successful STAR Act, which was first passed in 2018. That bill helped provide funding to state cancer registries, from which this report's data was pulled. Beyond just that funding, the bill also spurred research into survivorship and has helped support the collection of valuable biospecimen. I think a lot of us already know how rare specific tumors are, and as such, the access to tissue sample from those very rare tumors can be limited for researchers. And the STAR Act has gone a long way in helping to ensure that access to rare biospecimen is available. The second piece of legislation is the Accelerating Kids Access to Care Act. This bill would eliminate burdensome delays that some families experience when traveling outside of their state for treatment. We know that a huge portion of our families need to travel for care, and those who utilize their state Medicaid system must have their providers submit to a lengthy process to be approved by their patient's home state. And this bill would provide exemptions to doctors treating pediatric patients as long as that doctor is in good standing within their own state's Medicaid system. We know by looking at the report that any delay in care really can be life-changing. More information on these bills can be found on our website under the October Advocacy Alert. I believe someone is going to share that in our chat for anyone that is interested in reading more about that and what kind of action that you can take. Outside of our advocacy efforts, PBTF remains totally committed to funding research that will lead to breakthroughs in treatment. We also continue directly serving our patient families through our family support team. If you or anyone you know needs help, I urge you to reach out to them. They're here to help you in any way that they can. Finally, I wanted to thank all of you for showing up and learning more about the report and our efforts to change things. I know it can be hard to listen to or talk about this stuff, but your presence here is appreciated more than you know. And we're so excited to partner with everyone that is on this call, no matter what space you come from. Please reach out to me, reach out to Heather, and we can start working together to support our kids.
Thank you, Mike, for sharing all of that. And thank you, Dr. Ostrom, Dr. Coven, and Mike for your presentations today. As everyone has mentioned, please go ahead and put any questions you may have in the Q&A down at the bottom of your screen. I'd like to go ahead and ask our presenters to unmute, turn your cameras on. And at this time, I'm also going to welcome to our panel, the President and Chief Mission Officer for the Central Brain Tumor Registry of the United States, Carol Krechko. Carol, thank you so much for joining this panel today for the discussion. I appreciate it.
Well, I'm very pleased to be here and thank you very much. I share a lot with the community that is watching today, as I am the mother of a child who passed away from a medulloblastoma. So I know what you feel. I know all the questions that you asked and how difficult it is to have a child with a brain tumor.
Thank you so much, Carol. I'm actually going to start with Dr. Ostrom and with Carol on this question that came in at registration. Is the statistical rise solely attributable to advancements in detection for the brain tumors?
So that's a great question. Historically, we did see a really big increase in brain tumor incidence and this kind of data in like the 80s and 90s that was definitely attributable to improvements in access to diagnostic technology and, diagnostic technology in general. So I think that the period where that's having a big impact on incidence of brain and CNS tumors is kind of more come to an end. Although we do have other things that affect kind of increases, which are improvements in data collection as we have moved into, EHR and EMR and different kinds of technologies that make sure that we are really counting every new case and getting really complete data. So that definitely has a little bit of an impact as well.
Okay. Sticking in the data realm, and Scott, you might also speak into this after Dr. Ostrom, but what data points are still needed but not available yet?
So, and this, I think Scott kind of touched on this in his presentation, is that these integrated diagnoses and these new entities that have been included and identified in the last several years, that we don't necessarily know how many new cases of those there are in the US because we don't have those codes in the system. So there's a lag with, identifying those that kind of limit our ability to really make sure we know how many new cases like that there are. So that's a major thing that I think, Carol has been very involved in trying to make sure that we're getting that data, but it just takes some time. So that's, I think, would be one of the major things that I would say.
Yeah, and can I jump in here a little bit? I had a meeting this morning which entailed electronic reporting of biomarkers mainly. And I want you to know that the legislation that you all supported with the STAR Act made an enormous difference. And what you don't really get the feedback that I wish you did, but so I felt compelled to give you that feedback. but there's computer languages that have to be standardized so that we can collect these data. The STAR Act persuaded Congress to make it mandatory to use a very sophisticated and wonderful computer language called FIRE. And this has been, what has happened is it's been made mandatory. So the STAR Act actually, besides pushing that and supporting that, they also, in their committee, people who worked for this and researchers actually were able to provide a way for the tumor registrars to use the language by doing what we call like crosswalks. So it's very, very important that you understand how important support and advocacy, and it really does make a difference especially on this level, because we want more of the data that Dr. Ostrom can, provide for us. And so analyze. She needs the data. Data are wonderful, but we really need more of it. So kudos to everyone who helped with that.
Thank you. Thank you so much. Dr. Coben, do you have anything to add from the clinician perspective on data points that are still needed out there?
Yeah, I'm happy to jump in. So I will talk to the overall diagnoses first and foremost, which I think our hospital is probably the only institution in the country that actually started a surveillance clinic for kids who have incidental findings, so incidental brain tumors on an MRI for another reason, and have started following these patients. It's interesting that these kids are not truly or typically considered children with brain tumors, right? But if you look at the radiology report, most often they are diagnosed as some type of low-grade glioma or low-grade brain tumor. But the risk of going in to do a surgery is probably harder or not worth the benefit to just watching and observing. And so, again, it's probably a small subset, but again, over the past year since we launched this clinic, we've probably seen 30 or so patients alone. And if you're thinking that's one center and extrapolate that, that's a decent amount of patients across the country who we think, and as out of a need, think they're getting lost because no one really knows their official diagnosis because they haven't had a biopsy, right, in the traditional sense, but have felt a real passion to make sure they're not lost. So that's one. I think for me, as I think Heather and Jen know, and maybe some in the brain tumor world know, my kind of immediate passion is delays in diagnosis. And so, if I could finish my career and fast forward and be able to collect delays in diagnosis on every patient accurately and implement that into the CBTRUS, hint, hint, I know Jill Barnholt Sloan has heard this many times. And Jenny Colin is actually one of my good friends and colleagues on this work. And so I think, we have to understand that the journey for a patient with a brain or spinal cord tumor starts before we even meet them. And understanding that there's going to be some period of time before that diagnostic window that we need to start collecting and understanding the journey from that aspect. I think it speaks to Mike's discussion point on insurance issues and access issues. I think the last thing I'll say is where I think CBTRUS will be really helpful in the long term with more survivors is cancer predisposition. And, I think we all say that, and the data show that about 8 to 12% roughly of all kind of childhood cancer is related to a predisposition. So some pre-existing reason for developing a cancer. I think that field is evolving, and I think we are learning more and more quickly about what does predispose to childhood cancer. And I think the CBTRUS will be really helpful over the next few years as we get better with pathology, better with coding these kind of cancer predisposition syndromes on what is truly linked and what is not linked. And I think that is a really exciting part of the field that will be up and coming. That wasn't a short answer, but hopefully it did it did hit home some key places.
It absolutely did. Thank you for that.
And if I could just underscore all of this, I think all of this really speaks to how important the STAR Act reauthorization is. If we want to ensure that these registries have the proper funding, this bill needs to pass. And right now it's stuck in limbo. We'd like for it to pass before the end of the year. It has broad bipartisan support. It should pass before the end of the year. We just need to try to convince our legislators to prioritize it. If it's not passed this session, we start all over again in trying to get people to co-sponsor it, which would just add an incredible amount of work to the bandwidth of our advocates. So we have support. It's on their desk. We just need folks to remind them that it's there and it could be voted on before the end of the year.
Thank you for that, Mike. We had a series of questions come in from one individual, so I'm going to condense it down to just a couple questions to start off here. And really, this is probably for Dr. Koven and Dr. Ostrom, but a lot of stats were shown in this presentation regarding the incidence of childhood brain tumors. How much is really known, though, regarding typical outcomes of survivors in later childhood and beyond? And do we actually know the greatest needs of those survivors, or is it based on individual tumor types? Long question, I know.
Yeah, I could probably answer this fairly quickly from the clinician aspect and let Dr. Ostrom take the data. So a lot is actually known for, if you look at the St. Jude long-term data, so that's the childhood cancer survivorship study. I don't know if I have the ability to put it in the chat, but it's called the CCSS. The other one is the St. Jude Lifetime Cohort. Are two really big database, similar to the CBTRUS, right, that have followed many patients. I think in the CCSS about 15,000 patients, and they have cohorts actually dating back to the 1980s that have documented pretty extensively the late effects of childhood survivors of brain tumors. Documenting that. Just about anything that will occur to a patient. So let's take a 50-year-old who would probably have hypertension at that age. Things that we would expect for a childhood cancer survivor, things happen probably about 10 years sooner. So it's premature aging. So then you think at 40, you have hypertension. Problem is that with childhood cancer survivors and brain tumor survivors specifically, 100% will have more than one comorbidity. And that's more than any other cancer survivor. So leukemia, the other ones, you can expect maybe 20, 30, 40, 50% of those survivors will have a comorbidity. But if you look at the brain tumors specifically, they have the most and have all of the comorbidities. And so again, it speaks to how important. I think the last part is, where do you design a space for neuro-onc survivorship? And this has been a struggle at our own institution, and I've now just started out of my own clinic, is that adults, or even let's say just young survivors, don't often feel a place in general survivorship clinics. And so if you look at some of the bigger facilities across the country, Boston, Texas Children's, many of those programs have gone to a neuro-oncologist being the survivorship physician or provider for neuro-onc specific survivorship questions. And I think that is a huge opportunity in the field for funding, for building transition models to adulthood. And personally at Riley, we haven't really transitioned many young adults because many adult providers don't know how to take care of survivors, in that way. Many of our other general survivorship providers don't also know how to take care of all the kind of chronic or comorbid conditions that our children deal with. And so these are huge kind of clinical aspects of things that the field has to evolve. And I think it takes more and more caregivers speaking to these issues. These are advocacy issues, right? These are parent-driven issues that, my child doesn't have insurance when they transition, or doesn't have a place or a home when they transition, doesn't have a quarterback for the care. Their PCP is not going to be that person, right? They don't also understand the multitude of issues. I'll let Dr. Ostrom talk about, how maybe the CCSS or future survivorship data can be molded into, the CBTRUS.
Yeah. So one of the limitations of the type of data that we use is that the only, the only event that people are followed over time for is death, which in this population is not necessarily not the most common outcome. We have such a large, from our prevalence estimates, you can see there's a very large population of children and adolescents surviving, and even more so if you're looking into that population that has grown into adulthood and is, living as an adult survivor of a child or adolescent brain tumor. And I think that, resources like the Childhood Cancer Survivor Study and other institutional cohorts are great and have taught us a lot about, what that survivorship experience looks like for those kids. But, I think that the more that we are able to potentially, thinking just about what we could, do, is that those really only tell us about kids that are treated at specific institutions. So it also is really, there are populations of childhood and adolescent, brain tumor survivors that are treated at places other than St. Jude or other than, the big pediatric cancer institutions. And we don't know as much about what happens to them, which I think would be another, opportunity thinking about data that could give us a better picture of what that experience looks like.
Great. We often say as clinicians, St. Jude is a great place, but is not really like any other place across the country to be treated or cared for. And I think knowing the providers there, they would admit that. But the Midwest, specifically is not the same as Boston or California, right? Or St. Jude. And there are individual issues to us here that aren't going to be the same to those in other areas. And I think that's a huge, huge point.
That is a huge point, Dr. Coven. Mike, I want you to jump in here off of Dr. Coven's last statement. You and I have talked a little bit about that access to care and some of those barriers. Can you just touch for a minute before our final question on some of the work and advocacy that you've been focusing on to really speak to those areas that aren't touched by those larger institutions?
Yeah, we just within this last month, we met with legislators from Nevada, and I think Nevada is a great example for everyone to think about. The amount of providers, I think there's only one neuro-oncologist, pediatric neuro-oncologist in the state in Nevada. And certainly the facilities to treat children in Nevada is definitely lacking. Because of that, they are, I should say, the fact that Nevada is high in mortality rate, that could be one of the factors for its placement in the list. We have found that using the CBTRUS to inform our discussions with legislators has been incredibly effective. They now have a sense of the broader scope of the problem within our community, but also specifically within their state. And when we couple that with real life issues within their state, like a lack of the amount of providers or people that can correctly diagnose their child, we can then roll into discussions about the Accelerating Kids Access to Care Act. And it makes for a very compelling argument. So again, using Nevada as an example, the majority of these families are traveling outside of their state. They're traveling to California, they're traveling across the country to Boston and to Philadelphia to get treatment. And we have a real life example of a bill that would and could directly affect them if they're traveling for treatment and experience any kind of delay. So if you have, and this point has been talked about before, if you have a delay in diagnosis, that's time that's being taken off of your clock, right? If we have further delays for a bureaucratic process within the Medicaid system for your state, it's valuable time. It's not hyperbolic to say that it could be the difference between life and death for some patients. So when we talk about this, using data to really back it up, it's just so much more effective, and it has helped inform a lot of our efforts here at PBTF.
Thank you, Mike. Final question, and really it's just a brief thought from each of you. There were 8 different times in registration that we were asked the simple question of what can I do? Faced with this data, faced with this statistical report, what can I do? And realizing our audience today consists of advocates, volunteers, patient families, healthcare professionals, and other foundations. I'd like each of you just to give your thought on what this community can walk away and do today. Carol, do you mind if I start with you?
No, and I probably would have jumped in. So
Okay.
no, that's great.
Thank you.
Because I thought of the question of what I would respond to from the perspective of where your audience is here. And I had so much information that I wanted to share. And I think that's what you can do, is to share your information. So when someone comes around with, would you help with this study? Help them with it, answer those questions. The data make a difference. And now we can see that data makes a difference. We know it's quantifiable. It's the buzzword of everything. So really to answer those questions and to volunteer. Sometimes it might stimulate Dr. Coven to think of, maybe this is a study that would be interesting, to do. Support groups as well, discuss things, join together, and many voices. So, and of course, support the advocacy. That's really writing a letter or pushing a button, sending something that's probably pre-written to your congressman. That's very helpful, and it is making a difference.
Thank you for that. Dr. Ostrom?
I have to echo Carol's point about participating in research. Everything that we're able to do is because people are willing to participate in research and share their data, and it's such a gift that you can give to the broader community to participate in research. Also to echo what Mike had said, so much of the other data that we receive is from based on federal mandates, based on state systems, and just being involved in pushing support for those programs and improving the type of data that we're collecting to even be able to understand the scope of this problem.
Thank you. Dr. Coven, final thought?
Yeah, I think mine is the striking knowledge of 84% and, the most common childhood tumor. And I think with those 2 points, we have to remember and think about the invisible disability that our children deal with. And that's, a term that I think about for those survivors and many of our patients who it's not visible what they've gone through. And we have to remember them. And I think being part of these research studies, these data help push through for so many of our patients that have endured so much, but many in the outside world don't see that. And I think we as advocates do see that, and we have to be a collective voice to push forward for them.
Thank you. And Mike?
I think it's as simple as signing up for our advocacy program. Advocacy takes on many different forms at PBTF, and I would say don't be afraid to engage with us. We will find a way for you to participate in a way that that feels safe and comfortable for you. So I outlined 2 examples, but they're just 2 examples of many. So I'd encourage anybody that's interested to sign up and reach out to me, and I can try to help you in any way that we can.
Thank you so much. So we are a little bit over our time together today. I want to thank our presenters for sharing your time and your expertise with us. And thank you to our attendees for your participation and your thoughtful questions. We are going to be sending you a link to the recording of the webinar, and you will receive the slides at the email address you registered with, so you don't have to write down these links right now. The Pediatric Brain Tumor Foundation remains focused on our families' unique journeys and ways that we can provide a community of support. If you are a family with us today and would like to know more, please visit the link or contact us directly at familysupport@curethekids.com. If you are interested in joining the advocacy efforts and working together to amplify our voices for the children, please visit the link that was shared in the chat, as well as in the slides, and complete a brief form for Mike to connect directly with you. Mike's contact information, as well as mine, is on this final slide today, so please don't hesitate to reach out with any questions or comments you have. Thank you again for joining us, and have a wonderful afternoon, everyone.